Bismillahir Rahmanir Rahim. Assalamu alaikum. So, from today onward, we will study about the anti-tubercular drugs. And in the anti-tubercular drugs, there are two classes: the first line anti-tubercular drugs and the second line anti-tubercular drugs. So, first of all, we will study about the first line anti-tubercular drugs. So, it includes the drugs like isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. We will discuss each one of these in detail. But first of all, you can remember the first line anti-tubercular drugs by the mnemonics known as RIPES. R for the rifampicin, I for the isoniazid, P for pyrazinamide, E for ethambutol, and S for the streptomycin. They are also known as the standard drugs because they are cheap, they are more effective and routinely used, and the less toxic anti-tubercular drug. So first of all, talking about the isoniazid, so let's start. So isoniazid, it is also known as the isonicotinic acid hydrazine or INH. Isoniazid is highly effective and the most widely used anti-tubercular drugs. It has a bactericidal activity, meaning that it does not prevent or stop the growth of the bacteria, Mycobacterium tuberculosis, but kills them. They are active against both the intracellular, mean those Mycobacterium tuberculosis which are present in the macrophages, as well as the extracellular bacilli. So they are one of the most effective drug, because they can kill both the intracellular and the extracellular bacilli. Now coming towards this mechanism of action, that how does the isoniazid prevent or stop the or kills the Mycobacterium tuberculosis? So first of all, it enters the bacilli by means of passive diffusion. After this, it is activated into a toxic form, and this is done mostly by the catalase peroxidase known as CATG, which is biochemically a catalase peroxidase. Then this toxic form interacts with the mycobacterial NAD and NADP. This is not NADP. This is NADP, nicotine amide dinucleotide phosphate, to produce compounds, and these compounds may be of two types or much more, but we will discuss only about the two types of these compounds. The first compound is the compound which inhibits the activities of enzyme like INHA, which is a reductase, and the second enzyme case A. The first one is INHA and the second one is case A, which is a synthase. And inhibition of these enzymes inhibit the synthesis of mycolic acid, and this mycolic acid is an essential compound of the mycobacterium cell wall, and inhibiting the mycobacterium cell wall, it will lead to the bacterial or mycobacterium cell death, as it is inhibiting the synthesis of mycolic acid. So they are much more effective in a dividing cell. They are much more effective in the dividing cell. And the another compound is a compound which inhibits the mycobacterial enzyme known as dihydrofolate reductase, and this enzyme helps in the DNA synthesis. This enzyme, by forming the nucleic acids, help in the DNA synthesis, and by preventing the formation of DNA, they can kill or stop their growth or may kill them. So these are some compounds which are formed from the isoniazid, and in this way they can kill the mycobacterium bacilli. So let's talk about the resistance, that how these bacteria become resistant to this isoniazid. So it is mainly through the mutation in the genes like the enzyme, as we have already discussed, KG, catalase, peroxidase, KSA, synthase, and INHA, which is a reductase, and both these enzymes are helping in the mycolic acid synthesis. So by producing mutation in enzyme like these, it prevents the binding of isoniazid to these enzymes. So thus producing or forming mechanism. Coming towards the pharmacokinetics, so it is readily absorbed from the gut and it reaches the maximum plasma concentration at about 1 to 2 hours. We will discuss the pharmacokinetics in 4 headings: A for absorption, D for distribution, M for the metabolism, and E for the excretion. So isoniazid is readily absorbed from the gut, reaching the maximum plasma concentration in about 1 to 2 hours. Coming to distribution, it is distributed well over all the body in the tubercular cavity as well as in the tubercular cavities in the body fluids like CSF and can cross the placental barrier. The fourth one is the metabolism. It is metabolized by acetylation, and this acetylation occurs in the liver by the type 4 acetyltransferase, and the rate of acetylation of isoniazid is under the genetic control, meaning that there may be slow or rapid acetylator depending upon the presence of enzymes this type 4 acetyltransferase. Towards the excretion, so the metabolites are excreted mainly in the urine. Towards its uses, so isoniazid is the first line drug for the treatment of tuberculosis, as we already discussed. It is also used for the chemoprophylaxis of the tuberculosis, and it can also be used for the latent tuberculosis to eliminate its carrier state. So these are 3 uses of isoniazid. Now coming towards its adverse effects. So the most common and the first adverse effect is the hepatotoxicity. Hepatotoxicity is the most common. It is characterized by the hepatocellular damage and the necrosis of the liver. But the important and good point is that it is reversible on the discontinuation of the drug. If we feel the sign and symptom or know about the sign and symptom, we can prevent this hepatotoxicity by discontinuation of the drug. So the patient of the receiving isoniazid must be monitored for the symptoms like anorexia, nausea, vomiting, and jaundice, etc. So in order to discontinue the drug. And this hepatic damage or hepatotoxicity is much more, the risk of hepatic damage is much more in people like chronic alcoholics, older people, and the people at the age of 50 or above have about 2.3% chances of getting this hepatotoxicity due to isoniazid. There are also much more in the risk is also much more in the rapid acetylators and during pregnancy and after the post or during the postpartum period. The second adverse effect is the peripheral neuritis, and it is dose related toxicity, and this is much more at the dose greater than the 5 mg per kg per day, and it is due to the relative pyridoxine deficiency caused by this isoniazid. And isoniazid causes this pyridoxine deficiency, or this is also called as vitamin B6 deficiency, by mainly 2 ways. It has a structural similarity with the pyridoxine, hence the isoniazid competitively interferes with the utilization of the pyridoxine due to its structural dissimilarity. And the second one is that this isoniazid promotes the excretion of pyridoxine and causing its decrease in the plasma level. And this peripheral neuritis is much more in the people like slow accelerators, malnutrition, alcoholics, diabetes, people having AIDS, and the uremic, and those in the condition like uremia. But how to prevent this hepatotoxicity? So if we prescribe or give pyridoxine 10 milligram per day along with the isoniazid, this can reduce the risk of peripheral neuritis. And this pyridoxine can also be given to people who have the isoniazid induced peripheral neuritis. So the pyridoxine is a drug of choice in order to prevent this peripheral neuritis. The other side effects are the immune mediated like fever, skin rashes, arthralgia, the sideroblastic anemia, and this is due to the pyridoxine. And this pyridoxine, which is a cofactor for the enzyme which helps in the protoporphyrin synthesis, and this enzyme is known as aminolevulinic acid dehydratase. Aminolevulinic acid dehydratase, which helps in the one step of the protoporphyrin synthesis. And this protoporphyrin along with the globin chain, globin plus iron, form the heme compound, and thus decreasing the synthesis of protoporphyrin will decrease the heme and thus decrease in the hemoglobin concentration and causing sideroblastic anemia. The other adverse effect is the GI disturbance like nausea, vomiting, abdominal pain, etc., and the CNS disturbance like psychosis and rarely convulsions. So that all about the isoniazid. We will study about the second drug, which is the rifampicin, in the next lecture. So kindly stay tuned. Thank you. Jazakumullah. Assalamu alaikum.